We're honored to be here. O'Connor Professional Group is a behavioral health navigation service, which is basically a fancy word for saying a consulting company. We work with people with addiction, mental health, and eating disorders, providing interventions, consultations, recovery coaching, meal support, and we do a lot of family coaching. Everything just shy of running a facility or offering individual therapy or psychiatric support. So we help get the families to many of the providers in the room and then work with them as they're coming home to stabilize them in the community. So I'm going to let Zack come in and open up the presentation.
Thanks, Sarah. This makes me feel a little more at ease. Thank you for the introduction. So I'm the clinical coordinator with O'Connor Professional Group, which means I'm overseeing and facilitating our consultation processes and supervising our team of case managers who are working directly with clients in the field. As you can see, our topic today is a co-occurring eating disorder and substance abuse. So we're going to give a little bit of context, and then we're going to talk about some specific cases and an approach that we've found to be effective in helping individuals with this presentation. As has been discussed by the previous presenters, there's a lot of comorbidity, especially with eating disorders and substance abuse. An individual that is presenting with one of these issues is at much greater risk for developing a problem with the other issue. And this is specifically true, as we know, with bulimia and binge eating disorder, but is also true with anorexia. As you can see, I think the most striking statistic is that up to 50% of individuals with an eating disorder will abuse alcohol or drugs, compared to about 9% in the general population. So obviously that's a stark contrast. And, sorry. You know, there are a number of, so why are these things occurring why do they tend to come up at the same time? You know, there's a lot of shared risk factors between the two. There's a common brain chemistry. Family history is an important part, as has already been discussed. And they do tend to emerge or become exacerbated in times of stress. What I think is important to take away from this is that oftentimes as we notice one disorder and we notice certain symptoms coming up, they get addressed, and then the other areas aren't being addressed. So as one thing's getting under control, another thing's getting popped up. While they're co-occurring disorders often, they are unique and have their own nuances to them. And so I think it's important to talk about the common characteristics of the two, but not to get them confused that it is not one issue. There's two separate issues. As we see a lot of preoccupation, obsession and compulsion on certain issues. So with substance abuse, obviously it's drugs or alcohol, and with eating disorders, it's food, body image, health, eating behaviors, and there's a lot of secretive behaviors with both of these. You're going to be, binging in secret or purging in secret, hiding your substance abuse if that's the case. And they're both chronic, recurring, and life-threatening diseases. As we know, eating disorders have the highest mortality rate of any mental illness, and with somewhere between 4 to 5% of individuals with eating disorder will die from their disease. So, and I think what I just want to mention about the chronic, recurring, and life-threatening thing, I think this is really hard for families to understand, families and individuals. A lot of times when families come to us, and I imagine for most of you too, there's an acute issue. There's a very noticeable problem that's happening right now that needs to be addressed. And when once that is addressed, as we've talked about, insurance companies want to believe that the person is cured. Families want to believe that the person is cured, and the individual really wants to be cured. But what we all know from experience in the field and from the research is that there is a need for long-term and ongoing treatment and support. And I think Arden has an example of a client she was working with that I'll hand it over to her.
So what I think is interesting about the last bullet is that it's true for substance abuse. It's certainly true for eating disorders. And I can think of a family that we were working with in New York City. It was a 16-year-old young woman. Her mom had contacted us because she was concerned that her daughter, even with very extensive outpatient supports, including meal support from a nutritionist group and twice a week individual therapy and ongoing relationship with a psychiatrist, her daughter wasn't doing well. So she had tried to enroll her in an IOP. You've probably heard this story before. They eventually rejected her because they said she wasn't medically stable enough. So it became time for the mom to face the facts that she needed to go into inpatient treatment. Not only was there a huge buzz and a certain amount of anxiety over exactly which treatment center she was to go to, the discussion immediately went to how she was going to return to her performing arts school. And it took a long time for me to actually talk to the mom about candidly what a performing arts school focuses on and whether or not, in fact, that was going to be the best choice for her daughter. We have another case of substance abuse that we're working with, and this particular individual is going into went into a rehab, and the parents asked that the stay at the rehab be truncated so he could return to college the very day he got out of residential rehabilitation. So it just shows that this bullet, chronic, reoccurring, and life-threatening, isn't necessarily, it may be intellectually recognized by parents, but when it comes to their child, their kid is going to be able to make it on their own. They're going to be the one that's able to be the exception to the rule. So now we're going to talk about Jane. And one of the things I love is when people ask me, do you have clients who are motivated for services? I wait for the day for those cases, and occasionally we get them. But most people who use meal support, case management, recovery companions, they're not folks who have been to, who are coming to this process for the first time. So they tend to look a lot like Jane, 20 years old. This is based on an actual case. The diagnostic picture is that she has bulimia nervosa, alcohol dependence, and borderline personality disorder. She was seen in individual therapy to address some of these concerns. And while at college, surprise, surprise, the problems begin to escalate. The binge drinking incidents become more frequent and with more severe consequences. And the frequency of the binges increase, and she begins purging regularly. So the family calls us because they're concerned and they want some help. So what I think is always interesting on cases is the different perspectives that you get from both the family system, the clinical professionals, and the individual themselves. So Jane, as you might imagine, wants to be able to return to school and have things go as normal. She thinks she can handle her own recovery. This is every young adult, or I shouldn't say every, but the majority of young adults who walk through our door. We have it, thanks mom, no need to pay for this group, I got it under control. The therapist on the case feels that she's seen this picture before, and it's time for Jane to get some more significant help and go into a residential facility. And the family system is, just at a high level, probably one of the most conflicted sources. On the one hand, they want their daughter healthy, and they want to see her be able to engage productively with her school activities. But they also want her to finish school. So on the one hand, they do care about her well-being, but on the other hand, her being able to get what she wants by staying in school is a priority for them. So what was our process? A lot of what our company focuses on is developing a holistic case management plan. And what that means is that we're trying to get all the different parties that are involved to give input into what they think for the goal should be for that individual. So in this particular case, the team of professionals that was working with her assessed her and decided that she actually did need to go into residential care. It was decided that she didn't need to go into a hospital setting to be stabilized for either the bulimia or for the alcohol dependence. Upon successful completion for the program, Jane was going to be discharged. And this last bullet is actually where I think the rubber hits the road with our work, is getting the parents to exert what I call leverage. Now, every young adult, when I ever say the word leverage, I become their least favorite person on the hit list, which is fine by me. And the reason I say that is because we see so many families that when the person is productive, meaning that they're actually able to continue with some of their lifelong pursuits, which is characteristic of eating disorders. They're getting straight A's. They're on track to go to an Ivy League school. They can present in such a convincing manner that families have a hard time coming to grips with the fact that they may be actually having to put their foot down and say, you know what, in fact, we are not going to support you going back to school unless you are willing to engage in services. And here is going to be the plan. And I would say, for some families, you know, my own story is that I have a younger brother who went through 14 rehabs, primarily for heroin addiction. But in our family system, it probably took till the 6th or the 7th where he wasn't calling the shots, because you do, in moments where the person has some degree of clarity, they are able to be very convincing with the families, which I'm sure all of you see. So oftentimes in a situation like Jane, for a 20-year-old, financial support is the lever, and it's the way to get the person to engage in services. So the dual diagnosis treatment team, and this is one of the areas that I think substance abuse and eating disorders overlap, but this level of professionals for what we consider the, you know, on an average eating disorder case, not necessarily every single one will be involved in every case, but it is an extensive group that are potentially involved. So who are these members? A primary care physician with eating disorder specialization, a nutritionist, a psychiatrist. We say that a lot of our folks work with case managers, some with recovery coaches, and the case manager may in fact not be a separate member of the treatment team. It may be the therapist or the psychiatrist or the family therapist that is serving that role. A therapist, a family therapist at times, group therapist, and family members when appropriate. It's a long group of folks. We do find that the multidisciplinary approach really helps impact the results. I think one of the challenges becomes that if someone is co-occurring, that they've had a lot of treatment in the past, and having different people with different perspectives is important. However, one of the challenges becomes, as you can see, it's a long list of professionals. So one of the members of that team needs to be there coordinating care and communication. So I'm going to let Zack talk a little bit about developing the holistic case management plan and what areas we try to cover.
So I'm going to give a little bit of more information about how we think about case management plans, and then Arden will get into kind of the specifics of Jane and what her case management plan looked like to illustrate the work a little bit more. So when we think about a holistic case management plan, it's really, we're looking at the whole person across multiple domains in their life. So I think, you know, obviously you'll see recovery and treatment are up there. It's really important that those are on the plan. That's why they're coming to us in the first place. But we also really believe that in order for people to get better and to stay better, they need to be working on other things in their life also. Sense of purpose, and everybody wants to feel normal. We know this is hard work. It's not easy to recover from eating disorders or substance abuse, but especially when they're co-occurring. That's a lot of work. It's going to take a lot of time and energy, and when we're able to identify goals with the individual in other areas of their life as well, they may feel like they're not getting better just for the sake of getting better, but they're getting better also so that they can have more satisfying relationships. They can, you know, engage in school again, or get back to the career track that they had. You know, recreational interests, I think, as we know with substance abuse and eating disorders, people lose their identity at times, especially when they're been in treatment for a long time and have kind of lost touch with maybe what their real life used to look like. They don't know what they like to do. It's really common that we ask people, what are your hobbies? What do you like to do? Well, I don't know. You know, I drink and I purge, and you know, they don't really know what they like to do anymore and who they are. So with all those domains on there, we recognize that it would not be helpful or even reasonable to put goals for every single one of those domains at the same time. So we really work, I think it's essential that we're prioritizing what the goals are. Usually in the initial stage of work with an individual with us, the recovery and treatment goals are prioritized. They're at the top of the list. We need to address these things first so that the other work can be done and they can move forward in other domains. We want to honor the individual's autonomy, recognize that they should have a say in what they're working towards, but then also recruit the expert providers that they're working with, all of you, and really take their recommendations and their opinions on what level of care is needed and what things need to be addressed. So it's really looking at everybody, collaborating with the team, and going from there. Just a some strategies we use when we're thinking about what are good goals and what are not good goals. We tend to use the SMART strategy here. So goals should be specific, measurable, attainable, relevant, and time-bound. The one that often gets clients sometimes confused, they're like, you know, the rest of it makes pretty good sense. What about relevant? How do we determine what's relevant? And so, well, if you tell me you want to watch, you know, 30 movies on Netflix in the next 2 weeks, you know, that's probably not relevant to what the work that we're doing together. You know, if you want to go to, you know, mindfulness class a couple times a week, or, you know, have a couple of social outings with your friends in a week, that would be those are relevant goals. Goals should be a positive statement. So rather than not doing something, I like to think of what you are going to be doing. And whenever possible, I think it's helpful that goals are based on performance rather than outcome. So an example of a good goal would be that Jessie will attend all of her classes and submit her assignments on time this semester or for the next month. A bad goal would be that Jessie will get an A in her econ class, because really, maybe she's not capable of the A, maybe things will get out of her control, but she can control getting to class and turning her assignments in. So, all right, I'll hand it back over to Arden. She talks a little bit more about Jane's plan.
So as you can see, we like to keep our clients busy. Jane is very, very busy according to this plan. And this is, you know, I say it sort of in jest because it is for illustrative purposes. We try not to overwhelm clients who are already in a position where they are overwhelmed. But we do try and identify all the different relevant domains. So as you can see, the clinical treatment is and that would be one of the first ones, particularly in the beginning, that we're prioritizing until the person gets on a reasonable schedule. So weekly individual therapy, bi-weekly psychiatry, weekly DBT groups, monthly meetings as needed with the nutritionist, and monthly or more as needed with the PCP. So in this particular case, you know, this isn't so different than what a discharge plan might look like from a facility, and we often are using those to help create the basis for the case management plan. The reason we create one is, though, to monitor it over time, because one of my frustrations is when somebody goes to a really great treatment center, they get a fantastic discharge summary, which we're reviewing, and then they follow not one iota of the recommendations, and then there's a relapse or a challenging situation that comes up and the family sort of throws their hands up and says, oh, see, it didn't work. Well, the treatment did have an impact. It's that the recommendations weren't followed afterwards. So eating disorder recovery, you know, the meal plan is obviously one of the big pieces we're looking at. We're collaborating closely with the nutritionist, and we're only offering supportive services like meal support in the home if it's something that they think is appropriate. Sometimes we're doing exposure work in the community, maintaining a food journal. So again, these are goals that might be coming from the clinicians on the case. They may be ones that we're supplementing as well. Substance abuse recovery is at the top of the list as well. Going to AA, submitting to random drug screens. And then we do try to get, to Zack's point, recreation and other educational or vocational goals onto the plan fairly soon. You know, if you think about carrot and stick approaches for the individual, they often have, as Jane does, a specific goal they're working towards. So while the goal should be continuing to engage in recovery, I truly believe that there is a self-esteem built by engaging in some of these other activities where they can start to feel competent. They can go to a job and start to feel like they're gaining praise because they're showing up regularly. Or they figured out a new way to engage in self-care that they'd never experienced before. So having these as options on the plan, in addition to the clinical treatment and some of the recovery goals, is really important for clients to feel like they're progressing and they're really transitioning successfully into the community. So working with the treatment team, it's essential that the case manager is coordinating effective communication. Whenever it's possible, it's great if you can get together in person. This is often logistically pretty complicated, so doing phone check-ins is another alternative. I think the relevant data is a really good piece. Again, the larger the treatment team, the more options there are for the person to be weighed over here and not have the update go to whomever else is practicing with the group. You know, one of the things that we've found as we're in the home so often is we may notice things about the person's home environment. We may notice, for instance, a pill bottle that's sitting in the bathroom that we're not sure was prescribed by the psychiatrist. So really making sure that that information is conveyed back to the treatment team and that there's a plan put in place to address it. And then the last point I think cannot be emphasized enough, and it's hard to do because families don't want to talk about crisis or relapse in the beginning phases of someone transitioning home. You know, I've heard parents actually say that can't happen. And I'll say, I'll cross my fingers it won't, but I think it's important to recognize it in the beginning. And as a company that does a lot of crisis management work, you know, transports to facility and interventions and all that type of stuff, I think getting buy-in in the beginning from the entire treatment team, but particularly from the family who's often going to be the payer of services, for what you want to do if XYZ happens. And even if it's a couple of A, B, C scenarios, but starting to get their minds thinking towards this so that when there is a challenging situation, whether it's on the substance abuse side or whether it's on the eating disorder side, it is not a mad dash scramble and a poor placement opportunity that's put together because there wasn't another plan in place. Zack.
Thanks. So, again, a number of people have mentioned the importance of working with the families. It's been talked about a lot of in context of family therapy. What we're doing is quite a bit different. We call it family coaching, family support person. Every client we work with who has family that's involved with them, even if they're adults, but they're still heavily involved with their family, we are going to be assigning a family support person for that person's family, individual's family. It serves a couple of purposes. One is that a lot of times with our clients, we see very enmeshed boundaries here, and they're over-functioning for each other and codependent at times. And so we tell the parents, we say, hey, mom and dad, you're not actually going to talk to the case manager unless we're doing a facilitated family meeting. You're going to have your family coach. They're going to be the conduit for updates and hearing your concerns and relaying concerns that we may have. But really what they're going to be doing is helping you look at what you're doing in your relationships with the individual and your interactions. Not that you're doing anything wrong, but maybe there's things you could be doing better. Maybe there's things we could be doing differently to lead to different outcomes, and shifting some of the dynamics in the family that way. Also recognizing that the families need to, in order to best help your loved one, you got to take care of yourself. That's hard, and even though families know that, I think it's really hard to put into practice. And so our family coaches can really serve as a person to help them take care of themselves. Families come to us at all stages in the process. A family might come to us, this is their first time really seeking out any sort of treatment. They just realized there was an issue, looking to get somebody into maybe inpatient treatment. With those sorts of families, we're doing a lot of psychoeducation, really helping them understand the disease concept of eating disorders and addiction, and what is helpful treatment, what are kind of the realities of the situation, and also letting them know that there is hope. There is a tremendous amount of hope. Other families maybe have been in and out of the treatment world for years, and maybe there's, again, boundary issues and things like that. And we're going to be focusing on that work. So the thing I'm often telling my families that I'm working with is, I want you, Mom, I want you to be able to be the mom again. I don't want you to have to be the case manager or the care coordinator. You should really, when's the last time you just had a conversation about what they're watching on TV these days, or, which I guess in the context of what we were talking about, TV is probably not the best thing, but who are their friends at school versus how much did you eat today? How much did you drink today? How much do you weigh? Let us do that. Let somebody else free you up to have the relationship that you want with the person. So there's a number of different things we do. And another thing I think is really important is separating with families, what's your hope and what is your expectation? And families, I think, have a tremendous amount of hopes for their individuals. They maybe want them to go to college, maybe want them to get married, have a family, whatever it may be. Okay. That's great. What are the expectations? When I think of what an expectation is something that kind of really needs to be met in order to receive certain incentives or not receive certain consequences. So as Arden said, raising the bottom. So we'll do that with families. We'll use the financial support as a leverage, and it might be an expectation that they have to attend 3 AA meetings a week or attend their DBT group weekly. That's an expectation. Saying that somebody needs to have a certain career is probably not a healthy expectation. It's really shouldn't be the parent's job, right? So hopes versus expectations, I think, is important to think about. With the case management plan, it's really useful to reevaluate it, revisit the plan on a regular basis. Usually in the initial phase with somebody, we're doing that maybe weekly, at the longest maybe monthly, depending on where they're at in their treatment. After they've been with us for a while, that might be done a little bit less frequently, but it serves a number of purposes. I think it's a great tool to help the individual realize the progress that they're making. If the case management plan has been done well, there are things that they are going to experience some success. Maybe not on everything, but on a number of things, they should be moving towards their goals. And when they're not, it's useful to look at what has gotten in the way of that. So what are the obstacles and barriers towards moving towards your goals? You know, recognizing that when things haven't gotten done, it's not necessarily that the person wasn't working hard, but you know, maybe it's even no longer a goal. Maybe that's not something they're interested in. Goals change, you know. Crisis, relapse, as we were talking about earlier, is recovery possible? Absolutely. Is relapse part of these often, both of these, substance abuse and eating disorders? I think it is, and we see it with a lot of our families, and how to respond to a crisis and relapse is really, it's really important for families to understand, for the individuals to understand, and the providers they're working with to avoid feelings of shame and guilt when there is a relapse or a crisis. And how can we access the supports a little differently? Let's take a look at it. Once they're out of the acute crisis phase, let's take a look at what happened. What maybe went wrong this time, or what enabled you, what prevented you from using the coping skills you may have had, or accessing the supports that you had in place. Maybe we need to learn new coping skills. Maybe they're no longer effective for where you're at in your life. I think it's also important to recognize that research has shown people are often able to come back into their treatment or their work. We use the stages of change a lot in our work, and it's pre-contemplation, contemplation, action, and maintenance. We have a client we've been working with. She's 11 months sober from substances, has been doing a lot of great eating disorder work. She relapses, and she's devastated. She kind of she goes off and running for about 2 to 3 weeks. She comes back, finally, realizes she's had enough, she's exhausted, she can't do this anymore. Family's first inclination is more residential treatment. Now, this is somebody that has had residential treatment for both substance abuse and eating disorder separately, as well as some combined programming. It's clear that she needs some chemical detox from the amount of alcohol she's been consuming, but her weight is not at a medically concerning level. Clearly there's eating disorder behaviors have reemerged in the context of her substance use and the chaos that's in her life right now. But once she was chemically stabilized, we were able to go back to the case management plan that she had been using and recognize that there was an IOP that she could participate in and resume with her DBT programming, go back to the AA and NA meetings that she had liked before and get back into that program without needing to go back into residential. It's scary for the families, but also, as we know, insurance has questionable tolerance for how many readmittance they'll have, and you really need to make an argument. And if families are private paying, it's worth talking about that sometimes outpatient or starting kind of where you left off is possible because of the sheer cost. So that's how we handle crisis and relapse. So I think that is the end of our presentation, and I just want to leave you with a quote from Bishop Desmond Tutu, and hope is being able to see that there is light despite all of the darkness, and I think that's what we're doing, and I know all of us try to do that in our work with clients. So thank you very much.